I thought I'd talk to you about getting ready for surgical education and training. That's what SET stands for, Surgical Education and Training. I'm not going to go through the ins and outs of how you might prepare for a particular specialty and how you would apply for that. I think that type of information you'll get closer to the time. And also there's a lot of information that's available on the college website as it relates to the 9 different surgical specialties. So really what I wanted to do is just talk about a broader, more sort of helicopter view about how you should be preparing yourselves if you have an interest in surgery and surgical training. How many of you would have an interest in doing surgery as a career? Just hands up. There's no points for if you don't put your hand up. So maybe about a third to maybe 40%, okay? So I don't assume that all of you want to be surgeons. And those of you who want to be surgeons, sometimes I hear the comment, I'd do anything to be a surgeon, you know? But really you don't have to do anything to be a surgeon. You just have to do the right things to be a surgeon, okay? And I guess that applies to most other vocations. So this was actually written by this chap here, Anthony Llewellyn. He's a psychiatrist in New South Wales, and he runs this website for career advice. And he wrote this a couple of years ago about surgery. He said surgery is really popular. It's pretty competitive to get into, but nonetheless, we've got this image that we are pretty competitive, hard-working, yet a very rewarding profession. And I guess I would agree with those sentiments. But if we look at the data and the available information, you know, surgery is still popular. Compared to, say, just over a decade ago, it was probably the most popular vocation that medical students would list. And I'm talking about final year students. So this is taken from the Medical Dean's survey, so the medical school's outcome data. And at the moment, surgery's been pretty stable around, the third top preference. But if you look at the percentages of students who respond to the survey, it certainly has dropped, okay? So for what it's worth, just having that perspective might be important. Probably more important is some consistent data that's been published over the years. So I've just picked a couple of papers, and it's also supported by the medical school's outcome data. If you look at the current lot of surgical trainees, 90% of them will actually report that they actually made the decision to do surgery sometime as a medical student, okay? So that's pretty telling. I'm not sure how that compares to other vocations, other training programs, but that's pretty high. And not only that, when they examined, the reasons behind that, it would seem that some of these are predictive factors. Now, there's no doubt that more males would prefer to do surgery than females. Now, that may relate a lot to this role modelling down the bottom. I don't think it's a particularly male type vocation. Having said that, it is male dominated. So currently we have about 33%, so about a third of our surgical trainees are female. But in terms of consultant surgeons, it's half that, okay? It's probably around 13 to 15%. So we've got a bit of a way to go. And yet when I look at medical schools, they're just above 50% are female. So there is a gender difference. So I would not say that surgery attracts more males or surgery appeals to more males. I think that's probably more of a role modelling issue, because ever since we've had a move to try to increase or to reduce that gender disparity, there actually has been a shift in that dial, although very slow. But a couple of other key important factors, they really relate to how you personally view surgery as a career. And you look at it, you experience it, and you go, yep, that fits with my values, my belief of what medicine and clinical practice is like. It also fits in with your interest, and importantly, it relates to how well you feel you are capable of achieving what's required in surgical training and to achieve, to get to become a consultant surgeon. So that's that sort of aptitude, your sense that you can actually do something. So, you know, I might look at a particular activity, I'd go, there's no way I could be a skydiver, okay? It's just not, it doesn't appeal to me. You know, I might be able to do it, but will I be successful at it? Perhaps not, okay? So it's that aptitude to succeed. And that's probably the key, the topmost factor, okay, that comes across. The second factor actually is culture, okay, work culture. So people actually look at what it's like to be in a surgical unit as a medical student, and you work out pretty quickly, oh, I like the way that people interact. I like the way that they go about managing their patients. I like the way that they interact with other specialties, okay? So the culture is really important. And of course, some of you may be aware that surgery doesn't have a great reputation for parts of its culture, particularly how it's pretty hierarchical and how it treats its junior staff, okay? But that's something that we are well aware of, and we've actually taken significant steps to improve that. And hopefully in Adelaide, in South Australia, most of you, if not all of you, hopefully will have a very positive experience in terms of the surgical culture. And then closely linked to that is your experience as a student on a surgical unit. And it's actually not just the exposure, but it's a positive first experience, okay? So it's not the experience that you had on your 8th rotation to a surgical unit, it's the experience that you have in that first 1 or 2 rotations that actually is a major determinant, okay? So at least that is what we understand about how people actually align themselves and make decisions about pursuing surgery. Now, selection is pretty competitive. So I had a look at some data a while ago, and if you look at the last sort of 6 years of surgical applicants, you can calculate there that, you know, about 3 out of 10 applicants will get in, okay? So it's roughly about a third, just under a third. However, if you look at some specialties, like neurosurgery, cardiothoracic surgery, it might be 1 in 7, 1 in 8, okay? So, and then if you look at other specialties where there's a lot more positions, it's closer to 1 in 3, 1 in, 2.5, something like that. Okay, so it does depend on the specialty. But I think this is important to take into account because most surgical specialties now are moving to limited numbers of applications. And there's a very good reason for that, because at the moment, a lot of surgical trainees are selected in their 5th or 6th or 7th year after graduating from med school. And that's a long time to spend not actually doing formal vocational training. So it's important to understand some of the reasons behind these sort of dynamics. Anyway, that's just to demonstrate that it is competitive. Now, some of you have seen this slide, and when Professor Bruening and I went through med school and got into surgery, we sort of looked at the top bit there. We were medical students, we were sane, so we went down that right-hand path. We were pretty hard-working, and our attitude, well, I wouldn't say mean, but we were committed, okay? So really committed, really diligent, and we would prioritise surgical pursuits above anything else in our lives, okay? So that's a bit of a, I guess, a stereotype, and many of these things hold true. You have to be sane, you have to be hard-working, you need to be dedicated. But I think nowadays it's a lot more sophisticated than what this sort of tongue-in-cheek sort of algorithm would suggest. So nowadays we talk about competencies, and the College of Surgeons has 10 competencies. You can read them for yourself, and most of them are pretty self-explanatory, okay? It's important to understand this because historically, as a surgical training college of surgeons, we're sort of focused and did really well in our medical expertise, so that's your knowledge, in our technical expertise, that's how we train surgeons to operate, so that's your psychomotor skills, and also in our clinical decision making. But we didn't spend a lot of time in the other competencies. And then when the data started coming out with these other competencies, it became very clear that unless you have all of these competencies, your patient outcomes actually are not as good. So in fact, not being competent in some of these other areas, these other domains, actually predicts for poorer patient outcome and actually less safe care for your patients. So there's now good data to say that you need all 10 competencies, and some of these non-technical competencies or non-technical skills, soft skills, professional skills, you can call them what you like, you all recognise what they are, but those are now recognised as being absolutely essential for good quality patient care. And again, I think that's important at your level to understand that whilst we are a craft group and a lot of the training will focus on operating, it's not the end all, and it's certainly necessary, but it's certainly not sufficient, okay? And in fact, the colleges and in fact the Australian Medical Council would say that all 10 competencies are necessary, so they don't actually rank them in terms of hierarchy. Okay. So nowadays we talk about competencies. We also have to think about having selection criteria, and these selection criteria are based on the competencies, but they're also based on some other novel parameters, if you like, and they relate to selecting for societal needs, okay? So I thought we'd spend the rest of this sort of session, my talk, just discussing what you feel are societal needs and what you feel is required as individuals to actually succeed in surgical training. Okay? Because this is certainly where all of the vocational training programs, whether you do surgery, whether you do anaesthetics, intensive care, medicine, even pathology, they're all heading in this direction. So it's important that you have some awareness of that. Yes, we do have accreditation standards, and selection into surgery is highly regulated now. It's highly standardised, there's a lot of accountability. So the old tap in the shoulder and a couple of corridor conversations amongst a couple of consultants is certainly not guaranteed to get anyone into surgical training. Quite different to, again, when you and I went through. Okay. So, I'd just like some suggestions from you, some thoughts that you have about what do you think society needs of surgeons and of surgical practice, or a service of surgical care? Anybody? Josh?
Some engagement or internal motivation of the surgeons to engage with the community.
Yep.
And the needs of the community which they're practicing within.
Yep. So can we expand on this? What are the needs of the society or the community?
Well, I think some form of representation of, say, like the different demographics of that community.
Yeah.
That would help, like, form that doctor-patient relationship or the surgeon-patient relationship.
Yeah.
Maybe bridge some of the needs.
Yeah.
A bit more sort of directed.
Yeah. So we're really talking about surgeons or the community of surgeons being diverse enough to represent accurately or closely represent the communities they serve. So why is that important?
Something like that, where people in the surgical community understand nuances of different cultures.
Yep, yep. Yeah, so all of that, you know, and I don't want to downplay cultural safety. I mean, I acknowledge that there's a lot of jargon now, but when you look past that, it's actually important because, again, the evidence would suggest that if you have a group of doctors who do not identify with a particular community culturally in their values, then that particular group of community have poorer health outcomes. And actually, it doesn't matter whether it's surgery or not. But it can be amplified specifically with surgery, because one of the other problems that we have in surgery is a lack of distribution of surgeons equitably across our societies and our regions, okay? So yes, so one of the key things that society needs and communities need are people who come from their communities. And, you know, we all know Australia's a pretty diverse, culturally diverse place. Many of us are immigrants. Many of us have immigrant heritage and families. And those cultures with those differences actually impact on health outcomes. And so patients are reluctant to go and see a doctor of a particular gender or particular ethnic group because they have different expectations, and so for that simple reason you get different outcomes. And of course a lot of surgeons, all of us in fact, have our inherent biases. So we have, you know, we approach different patients in slightly different ways, and sometimes we don't know it, sometimes we're sort of aware of it, but we sort of push it down in the back of our consciousness, and really that actually also has an impact on the quality of care that we can give. And again, that impacts directly on the outcome of that patient. So one of our needs is to have a diverse surgical group, okay? And another one I've mentioned already is our maldistribution of surgeons. We have enough surgeons at the moment to service our population needs of 20-odd million people. However, we still have huge disparities of where our surgeons are. And so there's a push to keep increasing the number of surgeons who we graduate. Now, there's no doubt if we don't do that, in 10 years' time, we will have a shortage of surgeons. But I think the problem is made worse or exacerbated because the number of surgeons who we are graduating are pretty well metrocentric, okay? Are pretty metrocentric. And I'm not preaching to you to say you should be all going out to the rural and regional areas, because here I am in Adelaide, okay? And I'm based here. I mean, I do rural work, but I'm based here. So, but again, it's important to understand that, in fact, the government is actually pushing for the colleges, and particularly the College of Surgeons, to actually look at training, recruiting, training and retaining surgeons in rural and regional Australia. And what that has meant in terms of selection is that if you come from a rural background, you will actually have additional points to be selected into surgery, because that is now seen as an important merit other than your other academic achievements, that it actually has merit to be coming from a rural background. And there's some very strong, consistent information or data that says if you have a rural background, particularly studied and educated and grew up in the rural place, then you're much more likely to go back there and work as a doctor or a surgeon. Okay, I mean, there are other societal needs. We have huge disparities in outcomes with our Indigenous population. And again, that is a problem that the government is looking to the College of Surgeons to try to help redress. Now, we can't easily recruit Aboriginal Torres Strait Islander surgeons, but we do have initiatives around that. And the fact that you're not from, if you're not from an Indigenous background, doesn't mean that the problem is not yours. It's all of ours, so we all have to actually pitch in. Okay, not sure that there's too many other heavy sort of societal needs, but probably one just to mention, which I've already mentioned, is that gender disparity. Because at the moment, 15% of all surgeons are female, 33% of our graduates are female, so we're starting to have that pipeline, and yet 50%, just over 50% of medical students are female, so there's a significant drop-off. Let's talk about what it looks like to be a successful surgical trainee. And this is probably more aligned to what you can be doing to prepare yourselves in doing surgical training or being selected for surgical training. So think about a surgical registrar you've seen who you think is actually a good person or successful, being successful in their surgical training, doing really well. What sort of qualities come out in that particular person to you?
In my experience, whenever you've looked up to someone who's a registrar and had the impression that they're successful, I tend to find a common thread is that they're good teachers.
Yep.
They tend to be able to teach to a wider demographic and then pitch things at appropriate levels, which I think invariably confers the fact that they understand the content a lot themselves, but it's also an additive skill to be able to teach.
Yep.
I think that ability also allows the clinician to engage and inform consent a lot better as well with patients, to be able to pitch things and teach them through the process how that might look and that sort of thing.
Right. Yeah. So that's a really good observation. I can't argue against that. You said that your sort of model registrar, someone who's really good, is knowledgeable. They actually are good at communicating, not just to their patients but to the colleagues around them. But I think the other thing about someone who really wants to teach and takes the initiative to teach, they actually show an interest in people around them, and they actually have an awareness and empathy that people at your level actually want to learn, okay? That they want to learn, they want to enrich themselves, all of that, and they're there to actually impart that, okay? So it's a little bit of a selfless act, because when you see how busy registrars are, they don't actually have to take time out, okay? Of course, they get points for teaching these days, so that helps. If you're trying to get into surgical training, one of your surgical RMO wants to teach you, that's partly because they get points for that. It's always good to motivate them. What other qualities would strike you? Yeah.
So being hardworking and diligent is
Yeah.
very important.
Yeah.
To make sure you have quite an attention to detail and make sure that everything is done as it should be.
Yep.
As well, the other thing I think is quite important is being a team player. So making
Yep.
sure you share the teamwork amongst the other registrars and juniors, and I think that gains a lot of respect as well within the team and
Yeah.
the overall functioning of the team.
Yeah. Okay, so again, a few things there to unpack. Hard working. Now, when you say, when someone says, "Oh, I'm hard working," they're going for one of our jobs and they go, "Oh, we're really hard working." We have to ask them, what do you mean by hard working? You've said they're diligent, their attention to detail. That's really important. There's a lot of information that you go through when you're assessing a patient, you're managing a patient, and then you multiply that by 20 or 30 or 40. So that's how many patients you may have. Maybe 40 is pretty high, but it does happen. So you have your group of patients that you're looking after, and you've got to pay attention to that detail, because some detail is really critical. You miss that information, you don't communicate that, you don't get a good outcome sometimes. So attention to detail, diligent, actually chasing things up. What else do you mean by hardworking?
I think always putting in your best effort to make sure all your tasks are done, and
Yeah.
I think it goes back to checking over things and just I think just putting in a lot of effort and not taking an easy way out.
Yeah. So it's really been having a work ethos that says, I have responsibilities and other people are relying on me, and part of those responsibilities is not just doing my job well, but making sure that all the things that determine that it's a well done job is actually completed. So it's accurately done, it's done in a timely way, it's done with good humour, so you're not grumpy about it, you just get on and do it, you focus on it. And then the other thing you said is a good team player. What do you mean by a good team player?
I think from a senior, from a reg
Yeah.
And yeah, sharing the workload evenly, not leaving the jobs that are less desirable to someone else, and making sure that we do that.
Yeah. And when you become interns, you'll work with a whole lot of different colleagues, and you'll soon get to know which colleagues are really good as team players because they're there. First of all, they take on the tasks that they've been delegated, and then they look out for you. They actually say, "Oh, look, you look pretty busy. I've just finished mine. What can I do for you?" Okay. And the really good ones are the ones who will anticipate. They'll go, "Oh, it looks like this XYZ is going to happen this afternoon, so let's do this in the morning to try to then allow XYZ to occur," or whatever. So there's a lot of anticipation. So they're generally very good at managing their workload. We sometimes just call it time management, but it's really managing the workload, good at doing what they need to do, and also helping out with others, okay? Giving your colleague a really good, being supportive and helping out when you can. Okay, and the other thing which you haven't mentioned, but again, really important, is having someone who knows their limits, okay? So what you're trying to do is to say, I'm trying to impress the people who are around me so that they can give me a good reference. So I don't want them to see too many of my weaknesses. But at the same time, you have to be pretty careful about it, because if you're overconfident and if you don't ask for help when you need to ask for help, you will come unstuck. And the problem is when you come unstuck, potentially a patient is suffering, okay? So be aware of that. And so the good junior doctors who we see are the ones who actually perform well, but they also know their limitations, and then they have a very low threshold to call for help. And so when I work with a registrar or an intern even, I get the sense of how much I can trust them, and I guess we haven't mentioned it, but trustworthiness. And it's built on, if I say something, I can rely on them to follow it through, but I also know that at a certain stage they will come and speak to me if they're not quite sure what's happened, or they'll say, I did do this, but I made a mistake, or something didn't get done, or I forgot to do something, because we all forget things, okay? So that's really important, okay? All right, so we might wrap it up there, but I guess what I wanted to illustrate was that to get into surgical training, it's highly competitive. We have 10 competencies these days to work towards. And whilst it's important to develop your skills right across all of those competencies, what you shouldn't do is to focus on just one competency. Because, we have people who love teaching, and that's all they'll do. They'll focus on the one competency. We have people who are really good at communicating, and they just love interacting with patients, but then they let the other parts of their work suffer. And their colleagues start to get to know that, because they go, oh, they're off having a 2-hour family meeting when they could have finished that in 20 minutes and help out with the work. So really what I would emphasise to each one of you is to develop your clinical skills right across the board. So you need to have good knowledge. You need to have good communication skills. You must be very good at how you manage your workload. You need to be professionally reliable, trustworthy, be a team player, all of the things that you've highlighted. That will count a lot, because when it comes to asking for referee reports are a reasonably good predictor of how well people actually perform once they get into training, okay? All right, I'm happy to take questions. Got another, I've run out of time. I don't want to eat into Professor Bruening's.
No, we can take questions.
I just have a quick one. That comment about colleges moving into like a 3 application cut-off rule, I thought that was really interesting. If I interpret it correctly, you're saying the impetus behind it was more so that colleges are now taking people kind of PGY 5, 6, 7, and maybe that was a way to ameliorate it. this might speak to me as someone who's a bit more risk averse, but I would have thought that would have the opposite effect, where people would be very trepidatious and trying to cap out everything before they submit their first one.
Yeah,
Is there
yeah.
any-
Look, so I was being pretty superficial about explaining that, but there are multiple reasons. One reason is that we're not saying to the applicants, look, you've bombed out for the 4th time or the 5th time, you really need to start thinking about an alternative career pathway. So that's one factor. But another important factor is that we, as a college, we looked at our data and we worked out that if you have 3 or more unsuccessful applications to surgery, but you then finally get in, that cohort of trainees actually perform less well during training and in the final exam, okay? So there is some data to support that, and the AMC's asked us to go and look at that, and that's what we found. So there is a predictive value. The number of times that you apply, unsuccessfully apply, does have a correlation to how well you perform in surgical training. But of course, there are multiple factors that might determine how well you perform in training or why you didn't get into surgical training. And one of the other factors is the number of positions that are available. So that might apply in orthopaedics and general surgery and to some extent urology, where there's a lot of, and plastics, they have reasonable numbers of positions available. But if you look at the smaller specialties like paediatric surgery, cardiothoracic surgery, neurosurgery, they only have 4 or 5 positions in the whole of Australia and New Zealand each year. So they would not put a cap on the number of applications, okay? Yeah. But you're right, it's open to gaming and it's open to adverse, unwanted effects like, well, I think I'm ready now, but maybe I should just finish off and do a couple more presentations, boost up my CV, and then apply. And that gaming will always occur, okay? It will always occur. And I haven't sort of talked too much about all the components of applying for surgery. There's CVs and presentations and, whether you lead a journal club or whatever, some sort of management leadership skills and all of that. But part of my point tonight was to emphasise that you can do all of those things, but do not let that be at the detriment of being a good clinical doctor, because ultimately that's what we're looking for, that you need to be effective and sound and, really excellent as a clinician, okay?
Good question.
Yep.
What two of the competencies are health advocacy
Yep.
and cultural, obviously the cultural
Competence and safety, yeah.
Those are 2 competencies that I personally have felt that I'm not exposed to as much on things that we can do. What are some examples of things we can work towards building up competencies in both of those domains?
Yeah, okay, good question there. So one of the challenges that sometimes we see some of these competencies as esoterical, and the things that you might pick up ad hoc and by chance. But really what we've worked out is that in fact each one of these competencies are observable. They're certainly trainable, and you can measure them. You can measure the performance. So, a good example of health advocacy is seeing a patient and understanding that they have health problems such as that they're a bit overweight, or they smoke, or their diabetic control's not very good. And you might think, well, those are sort of medical problems. Well, those medical problems may preclude them having an operation. So you then have to work with them to actually say, okay, these are the sort of things you need to be able to start pursuing, and maybe start to make some of those connections for them. Get them to see a dietitian, talk to them about some of the medications or dietary methods of actually reducing weight. Cigarette smoking, how do you give up cigarette smoking? So difficult, from what I see. I don't smoke, but a lot of patients find it extremely difficult. So you need to actually support them in those endeavours. So, that's sort of the health advocacy. side of things. I think the cultural competence and safety is really about being aware and start to practice that, okay, this person is of this particular ethnic background and they have very strong cultural beliefs in certain things, and I need to be able to be aware of that, because it means that if I'm going to get their consent, I have to use certain language or certain approaches to actually allow that to happen. I might need to ask permission whether I can actually examine someone. Of course you have to ask permission all the time, but there may be some types of examinations in some people who may actually be taboo. So you have to think about other ways or ways around that. And so actually being aware of that at the time and then putting into practice sort of things that you may have learnt around cultural competence and cultural safety. And so it's not something that we'd expect that you just pick up as you're going along. It's something that we say, okay, this is the learning opportunity. Some of it may be courses, others may be things that we want you to read, and others will be put into practice. And they're the sort of things you then actually put into practice.